Hello and welcome to Engaged Research on Aging in New Jersey, a multi-chancellor-unit virtual symposium hosted by the Hub for Aging collaboration at Rutgers University. It is now my pleasure to introduce Dr. Emily Greenfield, professor at the Rutgers School of Social Work and director of the Hub for Aging collaboration, to start us off with welcoming remarks.
Thank you, Natalie, and welcome everyone. Thank you so much for joining us this morning. Natalie, I don't know if you can go ahead and advance the slides. Right, thank you. Okay, great. So we're really thrilled to have this opportunity to come together in Zoom land to talk about and present and celebrate and showcase and learn about cutting edge research that focus on aging in New Jersey and that aspire to achieve both social and scientific impact, and really on the theme of highlighting the importance of partnerships both within our university, but equally important outside of the university, outside of academia, to advance research and social change. We'll go to the next slide. So just a quick kind of get on the same page with how we designed and oriented our presentations for today. We wanted to find work that operates at this cross-section of a focus on aging and a focus on engaged research. So what do we mean by both of those things, just to make it super clear? Because oftentimes we use these terms and we're not actually thinking about them in exactly the same way. So of course, with a focus on aging and being part of the Hub for Aging collaboration at the Rutgers School of Social Work, we care very much about experiences of later life and older adults as a particular population subgroup. But we also think about aging as something holistic, as something that we're all doing from the moment we're born, and really thinking about a life course perspective of thinking about aging as this dynamic process that happens across the entirety of life. And in terms of engaged research, there's a long tradition in a lot of different disciplines to think about different participatory methods or action research. We use the term engaged research as a very broad umbrella term, a big tent that can invite a lot of different perspectives that share the characteristic of research projects that are advanced through cross-sectoral partnerships. And it can be with a variety of different types of organizations working on a research project. It could be a variety of kind of epistemological positions about power dynamics and relative roles across the different partners, but thinking very broadly about engaged research as working through partnership across sectors as part of the research process and outputs. Next slide. Okay, so we're really proud here in New Jersey. We have 140 people registered for today's event. And we're thrilled to see that more than half of you are here live with us today, and hope that many are able to watch the recording asynchronously after this morning. Interestingly, of the 140 registrants, 43% identified as being affiliated with higher education, the vast majority of which is in Rutgers, but not exclusively to our University of Rutgers, which really shows the appetite for coming together and thinking about engaged research on aging across sectors. And so in terms of the affiliations of many other people who express interest in today's event, we have advocacy organizations, government agencies, service providers, a variety of types, grassroots leaders and coalitions, as well as institutions for lifelong learning, including libraries. So we really are thrilled to have this inclusive space. We welcome you all. Next slide. Okay, and the whole point of being here is to hear the work that's actually happening. And we're super proud to feature research projects and collaborations occurring across 3 chancellor units. We'll begin with our colleagues here at Rutgers, New Brunswick on aging in place and older adult housing. Then we'll have our next presentation from leaders at Rutgers Health on the New Jersey Health Study and the role of community engagement. And then finally, we'll have Kristin August present from Rutgers Camden about a diabetes family coaching intervention for Spanish-speaking Latino populations. And we're very pleased also to be able to have Dr. Andrea Hetling with us here today from the Rutgers Blaustein School of Planning and Public Policy to offer her commentary after all 3 presentations through discussant remarks. Next slide. After we go through our content delivery with our presentations, we will have some large group discussion time permitting, and then we will go ahead and open up breakout rooms toward the end of our scheduled time together, where people can select into rooms assigned to each of the 3 different presentations. So if you have a particular question or interest in any of those 3 presentations, we invite you to find your way into the breakout room for that speaker set and be able to engage with the speakers then. Then we'll come back in the last 5 minutes for some closing remarks and announcements and adjourn at the top of the next hour. So next slide. Great. So without further ado, I'm going to go ahead and hand the mic over to my colleagues, Dr. Ayse Akincigil and Amir Koren. In the meantime, I invite everybody to continue introducing their wonderful selves in the chat. And please also feel free to put questions in the chat. I'll be moderating the question and answer period and keeping an eye on the chat to see what we have time to ask as part of our time together. So thank you.
Hello, everyone. It's such a pleasure. We're really excited to share our research that aims to strengthen aging in place. This presentation is about an innovative Medicaid-covered model supporting older adults living in subsidized housing, publicly subsidized housing, and helping them age in place. My name is Ayse, and my colleague Uri is here. We'll be presenting together. Next slide.
Hard to hear her.
How is this now? Is this better?
Yes, we also invite people to go ahead and use your closed captioning also to enhance the audibility or the content delivery if you're having a hard time hearing. And you can just go on your Zoom controls and click show captions at the bottom and should be able to turn your captions on. Thank you.
And I would like to start with acknowledgements at the beginning of our presentation because particularly our academic partners, because this research wouldn't be possible without them. The academic community partnership is the foundation of our research project. Our work was funded by the Henry and Marilyn Taub Foundation, as well as the New Jersey State Policy Lab, but all of the viewpoints that we're presenting are our own. Other than Uri and me, we have a very solid group of researchers at the Rutgers University Hub for Aging Collaboration, including Emily Greenfield, Karen Zurlo. We have an amazing data analyst, Dama Bishop, and we have 2 research assistants, Cassie and Jasmine. The project uses various data sources. Those are our federal partners. Some of our data came from, can you go back, please, Natalie? Yes. Some of our data came from the Center for Medicare and Medicaid Services, the U.S. Department of Housing and Urban Development, and most importantly, our community partners, the providers of this innovative model, assisted living program. And our providers are organized with a coalition, and Candace Robinson is supporting that coalition. That's the civic leader. So we were able to hit all the marks on Emily's slide regarding the public, community, and academic partnership. Next slide, please. So let me tell you a little bit about this partnership. Natalie, what we bring into the table is the academic application of related expertise with the discipline of the mean is, in our case, the intervention science and health services. Our ALP coalition and providers, our community partners, make sure that our research is grounded in ALP needs and interests, making sure knowledge generated contributes to their decision-making process, program improvement, and policy formulation. Natalie? And what's important about this is a concurrent bidirectional engagement. With the initial engagement started with a summative evaluation proposal from us to the coalition. And then as this concurrent bidirectional engagement developed further, this became a formative and summative approaches to strengthen thinking, where the research questions themselves are developed in partnership with the ALP providers. Regarding the summative part of the program evaluation, we first started with a very detailed program description based on legislative and state document reviews, including, licenses to provide all these ALP services, and key informant interviews with the providers of these services. And the second part of the summative is the SWOT analysis. The thing about the program description, we not only articulate the internal components, but also describe how state policies and procedures inform and shape the processes and the operational strategies of the ALPs. The SWOT analysis provided the framework to assess the program's effectiveness, scalability, and sustainability within the broader landscape of aging policy and practice. The third part, the outcome evaluation, I will talk about it if the time allows me. I'll give you the outlines of it if the time allows. In my next slide, my colleague will describe this innovative model that enabled older adults living in subsidized housing in place.
Hello, everyone. So what exactly are assisted living programs, ALPs? Next slide. An ALP provides support services to low-income older adults living in publicly subsidized housing, enabling them to age in place safely and independently. Next. Some of ALP's key features and its hands-on assistance with activities of daily living, medication management, meals, nursing, and social services. Next. ALPs stand out from the more predominant model of facility-based assisted living, also known as assisted living residences, ALRs. Unlike ALRs, where housing and services are bundled together, ALP's key feature is a decoupled services model. ALPs provide services within a resident's existing subsidized housing unit without requiring relocation to a licensed facility. These features of the ALP allow residents the flexibility to stay in their own homes and maintain community ties. ALPs also expand the care options to low-income seniors who might not afford private pay ALRs. From the provider side, ALPs are cost-effective as they allow lower startup and operational costs compared to building or running full facilities. Next slide. Our program description includes various flowcharts. These flowcharts identify specific policy-driven process gaps, such as bottlenecks in client flow, that directly impact the program's success. In the example in front of you, we provide a visual representation of how state policies and procedures impact operations. This flowchart describes a tenant living in a subsidized senior housing with an ALP located in the building. The client is presumably eligible for Medicaid-covered ALP services. This flowchart describes the steps that needs to be accomplished so that the ALP can serve the client and bill Medicaid. This visualization also improves translation to legislation. Medicaid's asset eligibility limit as a major barrier to the program enrollment. Next. Here we visualized how the legislation links to the ALP processes. As many of you are aware, the bill A4612 to raise the asset limit in New Jersey has been introduced to increase the Medicaid asset. Next. Going to our key findings of our SWOT analysis, we found the following key strengths. Next. ALP functions as centralized care hubs by establishing their offices within the subsidized housing facilities and providing services to all enrolled participants within a designated area. This allows efficiency in service delivery, ensuring streamlined and accessible care for residents. This model improves coordination of care by integrating medical and social services while reducing barriers through proximity to residents, supporting their ability to age in place. As I mentioned earlier, ALPs provide a cost-effective alternative to ALRs and nursing homes. Overall, ALPs are less expensive, saving Medicaid significant costs. Also, ALP's operation model allows for an adaptive flexibility, accommodating staffing and hours based on the resident's needs. As ALP's services are administered within the community, it makes them a conducive agent supporting aging in place. Next. Moving on to the weaknesses section of the SWOT analysis, we found the following key weaknesses. Next. ALPs may find it challenging to achieve economies of scale. ALPs rely on enrolling a minimum number of Medicaid-eligible clients within each housing facility to break even. Initial slow and low client enrollment can result in higher per client costs, straining financial sustainability. Furthermore, ALP face client recruitment barriers. Complex Medicaid eligibility requirements, such as income and asset limits and strict clinical thresholds, delay client enrollment. Lastly, while essentially ALP funding is mainly based on Medicaid, thus potentially ensuring a stable funding stream, ALPs often report a financial strain from reimbursement delays. The current Medicaid billing processes, which are managed by 5 different MCOs through the NJ-managed LTSS program, are often slow and inconsistent, leading to cash flow issues for ALPs. I will allow now Ayse to proceed on a more positive note regarding the opportunities section of the analysis.
Opportunities. The most significant opportunity is the potential demand for ALPs. We now have I'm going to explain what this map is. So you will see the potential demand. We have this publicly available interactive map of all the older adults housing units in New Jersey that can accommodate a financially sustainable ALP. This map was just published and it's still in its pilot stage. It literally got published yesterday. And we welcome you to take a look at it and give us feedback because, like I said, it's at pilot stage and we look forward to hearing from you in terms of how we can improve the map. So the ALPs on this map are the green triangles. And the housing the properties that can accommodate an ALP that's presumably financially viable are all in blue. So these are all the opportunities of expansion for an ALP operation. Next slide, please. Here, we are actually describing the opportunities by county because ALP rules and regulations and licenses, sometimes I believe it's hard, although there might be some changes coming up, is county-based. So these are the buildings in each county. On the y-axis, you will see the capacity or the size of the building that can potentially house an ALP. For example, in Hudson, we have ALPs that are even large. We have buildings that have more than 400 units. Warren has the smallest number of buildings that can sustain an ALP. In total, we identified 362 properties that fit our criteria of financial viable. Well, I would love to end with a positive note, but a SWOT analysis is never complete without a threat analysis or challenges. I'm not going to talk too much about this because we're all living in it right now. Any threat to Medicaid program is a threat to ALP. Medicaid is a major payer for their services. Medicaid pays per person per day for the ALP services. Another challenge we identified was workforce shortages, which is also an external threat to the provision. You're also very familiar with what happened during the COVID with the workforce shortages for the entire long-term services and support industry. So that's also threatening ALPs. That's an external threat to ALPs. Regardless, although there are hurdles to overcome, the potential demand for ALP services is substantial. The ALP model provides a unique and holistic approach to the elderly care, allowing older adults to age in their communities at a lower cost than other alternatives with personalized care models. Okay, I'm not gonna skip this. Next.
Heads up, Ayse.
Okay, thank you. That was it for me.
So yes, and I'm glad now to turn things over to our presenters from Rutgers Health, Dr. Dawne Mouzon and Victor Murray from NJ Health Study.
Great. Thank you all. My name is Dawne Mouzon. I'm an associate professor of sociology, and I'm also on the leadership team for the NJ Health Study, which I'm going to talk about today, along with Victor. And thank you to the organizers for having us to describe the ongoing work we're doing. So our plan for today is I will discuss the overview of the design of the study, and Victor Murray, who's our community health advisor and senior director of community engagement and capacity building at the Camden Coalition, will follow me to highlight the specific community engagement efforts and techniques we're using to reach historically underrepresented populations in the study. So quick set of acknowledgements, including our sincere thanks to the Robert Wood Johnson Foundation, State of New Jersey, and Rutgers Health for funding this important study. And of course, to thank our advisors and collaborators and colleagues within Rutgers and in the community organizations we've collaborated with, our staff, our participants who are willing to give us, tell us their very rich stories. So next slide. Yeah, so I'll lead off and provide a brief overview of the study design and aims, and then I'll pass it over to Victor to talk about community engagement. Next slide, please. Thank you. So just a quick overview of our leadership and management team, starting first with our fearless leader, Dr. Joel Cantor could not be here today. He's the PI of the study and the founding director of the Center for State Health Policy. I'm here, obviously. I believe Mara Shevtel from the School of Public Health is also here. We're all on the core faculty for the Institute for Health, Healthcare Policy, and Aging Research. And of course, our NJ Health Study Director, Stephanie Berggren, Margaret Kohler, Victor Murray, who you'll hear from, and our sampling consultant. So thank you all to them for their work. Next slide, please. Thank you. And of course, our study team. So just special acknowledgement and appreciation for our study team staff who are highlighted here. Next slide, please. Thank you. Just a few notes about the guiding principles that we abide by in the NJ Health Study. We sort of use this as a North Star of sorts for our work. So we hold a commitment to not only present our ongoing findings with the community, but also to work with the community to interpret those findings. We commit to supporting our community partners' work towards sort of addressing the needs we help to identify in the study. And we remain committed to treating all communities with respect and dignity, to be accountable to our communities, to be available and transparent, and be willing to learn from and be guided by our communities. When working with our partners, we aim to disrupt academic jargon. Academics like to talk in a lot of jargon, and to ensure that our work is accessible to all. And we are committed to utilizing community-informed definitions of health and well-being rather than the scientific ones we often rely solely on. Next slide, please. Thank you. So in terms of the goals and aims of the NJ Health Study, we have an overall goal to create or to generate practical, actionable knowledge to improve the health and well-being of all, but with a special health equity focus on diverse groups who are at risk of experiencing chronic stressors, such as immigrants, multi-generational families, racially minoritized groups, and low-income families. For our scientific aims, we're really a stress and health study, and we're broadly interested in understanding the prevalence and pathways through which established and emerging life course stressors contribute to health outcomes. And we also want to identify potential novel factors that either protect against the health consequences of the stressors that our communities face or amplify the impact of those stressors on both personal and population health. So those are our goals. Next slide, please. Thank you. Few words about our sample. We aim to recruit a total of 8,000 New Jersey community residents aged 14 and older. We are still very much in the field. Our sample has 2 arms. We are using a statewide probability sample of 4,000 participants that is designed to represent the state as a whole. And within this sample, we aim to ensure inclusion of families that are multi-generational, racially minoritized, and low income. So that's our first arm. Our second arm is comprised of immigrant populations, specifically 10 focal groups from the countries listed here, in addition to asylum seekers and refugees. So we're interested in recruiting Chinese immigrants, Korean, Asian, Indian, Filipino, Dominican, Mexican, Haitian, Jamaican, Nigerian, and as I said, asylum seekers and refugees. Given the present moment, we are considering the feasibility and safety of recruiting those with tenuous legal status, but the immigrant arm of our sample is really where our community engagement and outreach efforts are key in order to reach these populations who are often rightly skeptical or even distrustful of research, and even more distrustful given the current political climate. So for these reasons, we've invested a lot in community engagement efforts, which Victor will cover. I'll try to get through my slides so you can hear from him. Next slide, please. We have multiple sources of data. I'm gonna just show you, I'm just gonna highlight the broad points. We have a main interview that all 8,000 participants will complete by telephone, Zoom, in person, in line, and online in order to cast a wide net, reach as many people as possible. We have our main interview that includes an extensive battery of questions about stressors, stress buffers, amplifiers, cognitive assessment for adults age 50 and older. We're collecting actigraphy data, looking at sleep and movement. We're collecting biological markers. We are, for those who consent, we will also link to their medical and non-medical administrative records, so things like healthcare claims, healthcare utilization, clinical measures, use of social services, programs, even education and wage history, we would have access to for those who consent. And we're also collecting environmental data on home and neighborhood conditions, local policies as well. Next slide, please. Thank you. So given time, I'm just going to sort of zip through an overview of the key measures we are collecting. We do have a preprint of a study design manuscript that will soon be published, and that describes our methods and variables in far more detail than I can do in this short time. So do please consult that manuscript if you'd like more information, because I'm going to kind of zip through this. I'll have our website listed at the end of our slide. So in terms of health outcomes, we are studying mental and cognitive health outcomes, conditions like depression, anxiety, suicidality, dementia, and cognitive decline. We are looking at an array of physical illnesses and conditions. We're looking at disability-related conditions and factors that increase the risk of new health conditions, things like high blood pressure, diabetes, high cholesterol, and even trauma. Next slide, please. Thank you. These are the interview domains for the individual level stressors we're studying. So we're looking at life events and experiences, adverse child events, intimate partner violence. We're interested in discrimination, social determinants of health, perceived stress. And we have a domain looking at societal stressors. So these are sort of some of the novel stressors that speak to the present moment. Concerns about the role of social media in society, the state of race relations, state of immigration policy, gun violence, things like that. So we are studying those as our novel stressors. Next slide, please. Thank you. And finally, here is a list of some of the stress buffers and amplifiers we are studying, health services access and utilization, socioeconomic status, psychological factors such as loneliness, meaning in life, personality factors. We're interested in psychosocial factors, things like religious practices and attitudes towards the use of health services. And finally, social circumstances and engagement, such as civic engagement, engagement with news media, social support. So we're really trying to meet our aim of studying established stressors, those widely known risk factors that have been identified in some cases for decades, but while also retaining a focus on new and emerging stressors that exist in our present day world, which are sorely understudied. Next slide, please. I think this is my last one. Yeah, just an early look at NJ Health data. These are animated, I guess. Please feel free to click through them. This is from a data pool we did in August 2004 of almost 900 participants. We've actually more than doubled our sample since then. So now we have 1,900 participants. Just in terms of sample demographics, about 38% are over 60 years old. 69% of our sample are assigned female at birth. So this is an overrepresented population right now in our study compared to American Community Survey data. We do have 7% of respondents who identify as LGBTQ+, and 62% have a college degree or higher. About 15% of our immigrant sample is second generation, although we are working to improve our sample of first generation immigrants, which is right now a bit underrepresented in our probability sample. And then you see the countries of birth for the full sample there. I will end here. Next slide, please. Oh, timeline. Yes, so we're recruiting through at least the end of the year. We do have some early findings that we don't have time to share today, but we are developing lay language brief summaries for participants and stakeholders. In the interest of translational research, we've conducted briefings with state agencies and legislative leadership so that our findings don't just sit on the shelf. We want them to improve the lives of the communities we study. And I'll end there. And let Victor go on. If you have any questions, you could feel free to reach us or go on the website to find some of the resources I discussed earlier. All right, Victor. Thank you.
Appreciate it. And so, around the country, there's a conversation more and more about how organizations and institutions are trying to engage communities in a meaningful way, in an authentic way. And really, this New Jersey Health study is a good model for how academic partners can engage community in a research setting. And so, next slide. This Community Advisory Board really consists of a diverse group of advisors across the state of New Jersey who represent different communities, different regions, different sectors, really designed to have a diverse perspective regarding how this data, right, can be used. And so their role is to advise the study team, right, on how to engage participants in an equitable way, in a meaningful way, to ensure that the findings are relevant and useful, right, to community members, and also to help facilitate effective communication, right, with participants, community members, policymakers throughout New Jersey. And so, as Dawne mentioned, sometimes data can become stale. Right. As soon as the research is done, right, it's kind of put on the shelf, never to be consulted or looked at again. But really trying to understand how we can make use of this powerful data set in a way where it can be activated to drive change in communities across the state of New Jersey. And so next slide, please. And so when we think about our community advisory members' charge, well, you can see it laid out here. So we're not going to go through each of these for the sake of time, but I do just want to highlight a few. And so, in this study, it's really, really important for our community advisory board to really just understand the study itself. Right? What does the data mean? What is it saying? What is trying to be communicated? And ultimately, that's important because they represent the voice of multiple communities across the state of New Jersey. And their role is to provide feedback, right? Consultation on the data and how it can be interpreted. They're also in a role where they're providing expertise on recruitment and outreach strategies, right? Really thinking through through the most effective ways to engage specific communities, right? And so oftentimes when we use a word like immigrant, we know that that's very broad. But when you start to unpack, right, that word actually means different things to different communities, right? And so in talking to one of our community advisory members, he mentioned, when presenting research to his community, as long as an authority brings that research to his community, most folks believe it, right? Most folks take it as it is. However, when talking to a different community advisory member, they focused on the need for our research members to really build rapport with community, to establish relationship before going into, the weeds of the data, the study, right, and what it means. And so really kind of, again, thinking through the nuances of strategy and outreach, particularly when it comes to the different groups that we're trying to engage. I'll also just note, maybe a few slides towards the end, a few bullets rather towards the end there, the importance of our advisory member just playing an active role in dissemination efforts. Again, ensuring that, the findings reach organizations, community members, stakeholders who can use this data, whether that's using this data to drive, grant opportunities, whether that's using this data on more of a grassroots level, right? Just to create greater understanding of the challenges, the problems, so that interventions, programs can be designed that are most impactful and most useful. Next slide. So this is just to kind of give you all a sense of some of the current, right, outreach strategies. Obviously, we have our community advisory board, and they play a key role in terms of being credible messengers, right, in their communities. And so really working to inform, community members about the study and addressing questions, listening, right, to the different perspectives of members as data is being shared, collaborating on recruitment of participants, and really helping us to identify where we should be, right? Where we should be in a community so that we can most effectively engage, and then sharing, right, study results, the findings, so that we're ensuring that it's creating good health and well-being. And so Dawne talked a little bit about, eligibility, who we're looking to engage, how we're looking to engage people by means of interviews. We do that in multiple languages, have a very diverse group of staff members who are trying to make sure that all groups can be engaged in a very intentional way. And then just a little bit about our recruitment process. Some of you may be familiar with snowball sampling, which basically means we start with one and use that one as an inroads to many, right? And so engaging one person and then looking for other folks in that person's network, whether that's their social network, family network, to be able to engage.
Heads up. Heads up.
Yep. Thank you. Next slide. Yep. And so this is just to give you a sense of the diversity of outreach that we've done, from community-based organizations to working with faith-based organizations to working with other community advisory groups and networks. And again, this is not an exhaustive list of all the groups that we've engaged, but just to give you a sense of some of the groups that we've partnered with over the year, to again really make sure that we're intentionally engaging community in a thoughtful way. Next slide. And so this is a brief kind of snapshot of some of our outreach events. This is primarily focused on 2023. Finalizing the list for 2024. And so as you can imagine, our outreach has continued to grow. But in 23, we did a number of different events, some of more of a healthcare focus, others not so much more community-based focus. And then we did just a high degree of tabling. Right. And so just trying to promote awareness, right, understanding, and just trying to inform people about the study. As you can imagine, in the current environment, data becomes that much more important. And people are concerned about even their confidentiality, right, when it comes to data. right? And so really having thoughtful conversations with our community advisory members so that they then can have more conversations with community members to really allay their anxiety around studies like this and just research in general. And so I think that's the last slide. Yep, that's the last slide. And so look forward to spending some more time with you all later, perhaps in the breakout rooms, where we can talk more in detail and answer any questions or get any feedback from this group about how we can continue to grow and build this study.
So wonderful. Thank you both so much. I'm going to go ahead and transition now to our next speakers with the spotlight. So just bear with us as we get that set up. And yes, we have some questions in the chat as well, and are anticipating our question time as well, breakout rooms. But without further ado, we'll hand it off to Dr. Kristin August from Rutgers Camden.
Hey everyone, I'm excited to be here today, and I want to thank the Hub for Aging team for inviting me. I'm Kristin August. I'm a professor in the departments of psychology, health sciences, and prevention science at Rutgers Camden. And today I'm going to share with you some of the pilot work I've been doing on adapting a diabetes family coaching intervention for Spanish-speaking Latino populations. We actually just finished collecting data from we just actually finished our first intervention group last week. So I'm going to focus mostly on the process of the project. I'll share some very preliminary data with you. And then I've been doing community engaged research for a while, but as an ongoing learning experience for me, I'm going to share some challenges and future directions with you. So next slide, please. So diabetes is a major public health concern, and the prevalence increases with age. So about a third of older adults have diabetes. Approximately 90 to 95% of those are type 2 diabetes. And people with diabetes must learn to adhere to a complex medical regimen that requires them to adopt and maintain a number of health behaviors. And these behaviors are important for preventing complications, vascular complications, functional limitations, hospitalization, and early death. But for many people with diabetes, this is a complete lifestyle change. So not surprisingly, non-adherence to diabetes regimens is common. Next slide, please. Diabetes care is complex, yet there's no corresponding increase in time to account for this complexity during primary care medical visits. So diabetes education is an effective supplement to primary care for people with diabetes to learn about the required behaviors to successfully self-manage their diabetes. However, most people with diabetes do not complete diabetes education for a number of reasons. And among those who do, research suggests that diabetes education alone does not result in sustained behavior change. So additional techniques are needed to improve people with diabetes self-management. Coaching, which is a strategy that provides a structured, supportive relationship to foster people with diabetes motivation and self-efficacy, has become a common strategy to enhance patient education. And typically that's done using peers, community health workers, and healthcare providers. However, we know that most of diabetes management occurs in the home with the involvement of family members. Next slide, thank you. So family members can be involved in both helpful ways by supporting self-management behaviors, but they can also be involved in unhelpful ways by controlling or undermining those behaviors. And evidence suggests that chronic disease management interventions that incorporate positive types of family member involvement that promote people with diabetes self-efficacy have been shown to be beneficial for the patient, their family members, and their overall relationship. Next slide, please. Diabetes may be experienced differently in Latino individuals. So compared to non-Hispanic white individuals, Latino individuals are more likely to have diabetes, more likely to develop it at a younger age, and more likely to develop complications such as kidney failure and vision loss. There's also considerations related to diabetes management in this population. So there are sometimes language and cultural barriers with healthcare providers. So if you can't communicate fully with your provider or they don't understand your values and preferences, you're less likely to follow treatment instructions and make the lifestyle changes that are important for successful self-management. There might also be cultural beliefs and values that are incompatible with Western medicine. So for example, research suggests that some people of Hispanic origin want to use natural or traditional medicines instead of standard diabetes treatments. And then in the Latino culture, the idea of familialism is important to consider, such that the needs of the family often come before one's own health needs. Because of these strong family connections and the importance of food and meal sharing, when a family member has to change what they eat, for example, which is a really important component of diabetes management, it can affect the whole family. Next slide, please. Oh, thank you, already there. So the goal of this overall project, and it's a multi-phasal project, which I'll talk about in just a minute, was to develop and test a family coaching approach to diabetes self-management, and to examine whether this program improves self-management behaviors, well-being, and the overall relationship. And this was a multi-phasal project. So the initial phase was to develop a standard coaching manual and an interactive tool. This was done with the input from several diabetes educators in the community. The second phase was to pilot test the feasibility and efficacy of the intervention as a supplement to diabetes education. And this was done with English-speaking participants. And then the next phase was to assess the feasibility of this approach in a primary care setting. And this is actually when we determined a need to conduct the project in Spanish. Some of the providers that we spoke to had indicated that a lot of their patients did speak Spanish. And so we decided then to undertake the current phase, which I'm going to talk about today, which is translating and culturally adapting the intervention and assessment materials for Latino people with diabetes. Next slide, please. This is a collaborative project, so I'm not going to go over each individual, but it involves both academic and community partners. So the community partners in particular were involved in developing the intervention and culturally adapting it, helping us recruit participants, and hosting the sessions. Next slide, please. So just to go over the procedure, so the first part of this phase was to translate all of the materials, which was a huge undertaking. It involved all the intervention materials, the assessment tools, the recruitment materials, and this included 5 bilingual students as well as 2 Spanish language faculty who were the certified translators. And next, we sought to culturally adapt the materials to maintain equivalence in meaning and ensure cultural relevance. And we held 2 focus groups with Spanish-speaking Latino community members. And as a result of their feedback, we revised the materials. Next slide. And then the next stage was to actually do a small pilot of the intervention. So we recruited individuals with type 2 diabetes who were over the age of 18, who were Latino, Spanish speaking, and we had them select a family member to participate, and family member is in quotes because it was pretty much anyone who's involved in their diabetes management who is in close geographic proximity. And recruitment occurred in the fall and early winter. And we worked with or contacted about 36 organizations to help us with getting people to participate. And we found actually the most success with the Camden Housing Authority. We found someone who was a huge champion of our study. And what we did was we held workshops about health behaviors and information about the study. And that was our main source of participants. So we talked a little bit about some of the material that we presented in the intervention itself, and we were able to get people to attend it and get interested in the program as a result. Next slide. And so I'm going to go over the intervention sessions in a little bit more detail, but in general, they involved supplemental self-management support sessions, teaching family members and people with diabetes coaching skills. So for the English pilot, we also had a control group, but for this pilot, it was a little bit smaller, and we just had the intervention group. We assessed people at baseline prior to the intervention, immediately after, and then 3 months later. Next slide. And the intervention involved interactive group sessions led by a facilitator. So it was the person with diabetes as well as their designated family member or friend. And typically we had about 2 to 4 dyads involved. We did these sessions in person as well as via Zoom, although for this particular pilot in Spanish, it was only in person. We used visual aids as shown here. We did role playing, homework assignments for dyads to practice in between the sessions. And then we held 5 weekly sessions for about an hour and a half each. For the English pilot, we also did 2 consecutive Saturdays because we wanted to mirror what's typically done in diabetes education classes in our local community. But for this particular Spanish pilot, we just did the 5 weekly sessions. The first session went over brief diabetes education. And then the next 4 sessions, we taught the DIADS coaching strategies. So we taught them about reflective listening, using iMessages, and motivational interviewing techniques, for example. These are just preliminary results from the program evaluation. Like I said, we haven't collected all of our data yet, and we just started the Spanish pilot, but we did finish the English pilot, so you can see the comparison here. In general, participants in the intervention rated the quality of the program as good to excellent. They thought the program length and pace were appropriate. They could understand the materials presented well or very well, and they agreed that the program was worth their time, met their expectations, and they would recommend it to other people with diabetes. Next slide, please. And these are just some translated participant quotes from the recent program evaluation that we did. And so, as you can see, it helped the participants learn how to manage their diabetes, and it was useful information to them. So I do want to spend some time talking about some challenges and limitations, as well as future directions. Like I said, I've been doing community engaged research for a while, but there's always challenges, and I'm always working toward improving how I do this. So one of the biggest challenges I always experience in doing community-based work is, recruitment. Even though a lot of individuals showed expressed interest initially, that didn't translate into attendance. And this was particularly true for the Spanish pilot. So we had 12 people with diabetes express interest, so it would have been 24 possible participants with DIADS, but only in the recent group that we had, only 4 ended up attending, and they didn't even have their requisite family member or friend attend with them. So that definitely was a challenge. There was limited literacy in this population, so the survey completion time was very lengthy, and they needed assistance in Spanish. Unfortunately, we had limited team members who spoke Spanish, who were involved throughout the entire process of the project. So that really was problematic. And then, of course, the Latino population is a very heterogeneous group of individuals, and we expect there to be subgroup differences. But for this particular pilot, we were unable to tailor the intervention to each subgroup. So in terms of the future, we hope that, we would want to have continuous involvement from primary care providers and endocrinologists as well as community partners throughout the whole process of the project. And then having more Spanish-speaking team members who are involved again throughout the entire process. And then only focusing perhaps on one Latino subgroup at a time to, again, make the intervention more tailored for that particular group. And then I just want to talk about some overall project challenges. So as I mentioned, we've also done this with, an English-speaking pilot as well. And I didn't share, we do have some results from that I'm not sharing with you today. I'm happy to talk about those in the breakout room. But we saw some mixed results of the intervention. And one of the things we need to consider is what is the correct dose of the intervention to see positive outcomes and sustainability over time. The goal is that if family members are involved, they can provide ongoing supports in the home environment. But obviously having booster sessions would be helpful, and perhaps having some sort of ongoing support group format. One of the things we saw in both pilot studies was that the participants really enjoyed this group dynamic and felt really disappointed when the program was over and wanted to continue on, sharing recipes or tips about how to manage their diabetes. And then, of course, we would need to improve the methodological rigor of the study with a larger sample, a randomized control trial, and then really trying to understand the mechanisms that may contribute to the outcomes we found. We actually had participants self-report different clinical outcomes like hemoglobin A1C and glucose, but we'd want to do that more objectively in the future, for example, through chart review. And then as individuals who already have well-controlled diabetes are unlikely to change much as a result of this intervention, we'd probably want to be targeting people who had uncontrolled diabetes, who have A1C above a certain level. So that is all I have for you. I look forward to future discussions about this and conversations in the breakout room. Thank you so much.
Thank you, Kristin, so much. Natalie, want to go ahead?
Great, yes, thank you. It's been wonderful to hear from all our presenters today. I will now transition us onto our next section here of today's program. So I am now pleased to introduce our discussant for today's symposium, Dr. Andrea Hetling. Dr. Hetling is a professor at the Rutgers Blaustein School of Planning and Public Policy. Among her many accomplishments, Dr. Hetling served as a New Brunswick Chancellor Scholar from 2016 to 2021. She also served as a Provost Leadership Research Fellow in the Vice Provost Office from 2023 to 2024. In this position, Dr. Hetling led efforts to amplify chancellor-level leadership for community-engaged scholarship at Rutgers. We welcome Dr. Hetling's voice and perspective as our discussant at today's event. Dr. Hetling.
Oh, shoot. I unmuted myself and lost my notes. Where did they go? Here they are. Sorry. Someone has to mess up on Zoom. Glad it was me and not someone else. Thank you so much for having me here today. I'm really excited and also really humbled to be participating in this symposium. And I want to thank the organizers and the so impressive scholars that shared their research with us today, and all of you for being here and participating. I know that you're really looking forward to the Q&A and the small group, so I'm going to try to be brief with my remarks. I'm not an aging researcher, and I don't claim to be an expert in this field. Here at the Heldrick Center, where I serve as the Associate Director, we do have a project going on certified home health aides, so I'm here with great interest, and I learned a lot from the presentations. But I come with my community engaged research sort of cap or lens. Much of my own research looks at sort of applied mixed methods policy research on social policies with a strong focus on means tested human service and income support programs. I work closely with partners in both public and nonprofit sectors. But in addition to my own research, kind of over the past 5 years, I've had fabulous opportunities to work or kind of have discussions on a more macro level, both here at the university and also at OPRE, the Office of Planning, Research and Evaluation at the U.S. Department of Health and Human Services. These conversations have sort of focused on what community engaged scholarship and partnerships are, and how these should be valued and encouraged among academics, particularly those of us studying social policies. Community engaged research really represents a critical shift in how we approach knowledge creation, moving away from this top-down researcher-driven model towards this collaborative reciprocal partnership between the academics and those communities that we are supposed to be serving. The description, I love the description of today's event. It really focuses us, so the speakers will highlight how partnerships outside of academia advance their work and how their efforts to achieve both scientific, how their efforts aspire, to achieve both scientific and social impact. The three presentations today really bring this to life. Firstly, if we think about how the partnerships outside academia are advancing their work, I see this focused on the production of research. In community engaged research, this production is based on collaborative relationships that are bi-directional. In a research brief that I co-authored with my colleagues from my federal OPRE work, we wrote that reciprocal relationships are at the heart of partnerships. In this brief, we encourage researchers to intentionally build relationships that are not extractive. We should identify overlap in goals, priorities, and interests, and such relationships are built on trust and mutual respect. All of the scholars here today are participating in this important work that really redefines what expertise is, right? Kristin described this as a learning experience, engaging in this work. This means inviting community partners to shape the research questions, as Ayse and Yuri spoke about this in their work. In determining the appropriate methodologies, Dawne and Victor spoke about using community definitions of key concepts and not kind of coming with their own. Kristin emphasized the role partners had in actually designing the intervention. We need to bring in our community partners in later on in these research projects to help us interpret what the findings mean, right, from their perspective. It also means acknowledging and addressing power imbalances within the research process, and all of our presenters acknowledge that today. So this is the production part of research, right? Secondly, today's session was designed to highlight how their efforts aspire to achieve both scientific and social impact. I see that as kind of the end of the process, right? First, we produce the knowledge, and then we need to do something with it. Good community engaged projects have an impact beyond just our academic or scientific fields. It demands that research outcomes be useful to all partners and collaborators, whether that's through capacity building or advocacy or tangible policy or program changes. And we see this again in all of the work presented here today. Of course, this work is not without challenges. We heard a little bit about that today. It requires more time, more flexibility, and sometimes a willingness to let go of control, something that's sometimes hard for academics. Institutional barriers don't help either, right? And I really applaud the efforts of the Hub today for creating this space for us to come together, because the long-term benefits, the richer insights, stronger community relationships, and more impactful research far outweigh these challenges. And I've been so impressed with the projects today and really, again, bringing this to life. As we move into our small discussions, I hope we can learn more from our presenters. I am looking forward to that, and that we can all reflect on how research practices can move beyond extraction towards genuine collaboration. Thank you.
Oh, wow, Andrea, thank you so much. And thank you again to all of our presenters. I think on the whole, we had 3 really wonderful presentations with such rich diversity, but similar through lines. And Andrea, you did an amazing job of integrating the common threads and grounding them in your own experiences as an engaged researcher, and helping us all walk away from our time together with more organized thoughts on kind of the big picture themes of the meaning of all this work. So thank you so much for that. We're going to go ahead and take maybe 5 minutes or so to entertain one question for everybody, and we can spotlight all of our speakers, including Dr. Hetling. I think we'll add you to the mix. I'm just going to go ahead and add spotlights, and I'm going to ask a question that came up in the chat. It also came up in the Zoom registration information on asking the speakers to reflect a little bit about this historical moment that we're in doing this work, both in terms of the political context that we're all operating in and the vast accelerating transformation of the federal government in particular, especially as it concerns state-based work in New Jersey and work with local partners. When you think of the massive changes happening in our lifetimes at this moment with our federal government, if you're willing to reflect a little bit on, does that change anything? How not? Future prospects or ideas. Ayse, I see your hand go up?
Yes, I can start. I mean, particularly the programs that I'm studying, they have small margins. And they themselves, one of the weaknesses we found was due to the small margins, recruitment was very important for them. And their lifeline, their arteries are Medicaid fund, Medicaid funding goes through their arteries, and diversifying resources other than Medicaid could be important, but any threat to Medicaid, just like I said, will decimate these organizations. These are small human service organizations, and I'm so worried about the programs. But I'm going to keep it short since we have 5 minutes.
Thank you. Thank you so much for sharing that context. Yeah, Kristin.
Yeah, I've thought about this a lot and talked to a lot of people about this. So this project wasn't actually federally funded. I didn't mention the funding, it was internal. And I'm sort of used to doing research on shoestring budgets. That's kind of been, I'm used to, especially in Camden, where we don't have as much institutional resources for funding. And so obviously I'm not gonna, if I do apply for NIH funding, I don't think I'll be doing it anytime soon for this particular project, although I'm doing it for another project. And yeah, I mean, I feel like we're going to continue to do this work regardless of what it's called or who's funding us. I mean, this is important work. And for me, the work I do in diabetes in particular, it's not going to go away. The Latino population is going to have a higher prevalence rate. I'm going to continue to do it regardless of what's happening in the overall context. And I mean, obviously being mindful of people's, that I'm working with their concerns and being privacy and confidentiality. But yeah, I think the work has to get done and it needs to be done regardless of who's funding it or how we're going to do it. Obviously, I realize that some of the other work discussed today is a little bit more dependent on things like, federal funding. And so obviously that's not as easy for them. But for me, I'm going to just continue on.
Thank you so much, Kristin. I don't know if our colleagues from, EngAGEd, Dawne? Yeah.
Yeah, sure. I can, I think, highlight two issues. We're certainly facing the dual challenges of trying to balance the increasing need to have data on immigrant populations, especially in this moment, with their, of course, understandably increasing reticence to trust any institution. So, we kind of have to double down on our efforts to build trust with them in those ways, and that is a challenge. I don't think any of us can minimize the sort of challenge involved there. And in terms of funding, I mean, our study is primarily funded by Robert Wood Johnson Foundation, but we have been in the process of applying for sustainability funding with the National Institutes of Health, including a grant proposal I put in a few months ago. And it's a challenge. I think sort of the word of the year is going to be pivot for those of us who do work on these populations. We just have to find new funding sources and sort of double down on our efforts to study these populations, especially now.
Thank you so much. Yeah, Victor.
And if I might just add, a slightly different orientation, for this conversation from, a community perspective. Yes, it does mean change, but it's also important to remember that, systems have not worked for some communities in this country for a very long time. Right. And so we should not underestimate community, their ability to be resilient, right, even under hard, challenging circumstances. And so you even think about, healthcare specifically, hospitals, desegregation of our hospitals did not happen until the late, 60s, early 70s, right? And that didn't come as a result of goodwill or people now wanting to, invest in poor communities, right? It was none of that. It really had to do with Medicare, right, and billing. Right. And the government saying, unless you do this, you will not be able to, receive dollars, right, for the work. Right. And that's not too long ago. When we think about, the number of years, like that was in the 70s, that's about 50 years ago. Right. And so, again, communities had to work through, right, those type of systemic issues, right, even having adverse, obviously, outcomes. And so, so yes, obviously the current environment not ideal, and right, let's not underestimate folks' ability to even rise up in these tumultuous environments.
Victor, that's an amazing.
Thank you so much
for
sharing the both and perspective exactly in your voice, Victor. We appreciate it. I think we're going to go ahead and open up our breakout rooms now so that people who are participating here in our live audience can have time to ask their questions directed to the presentations of interest. Thanks for sticking with us to the end of our scheduled time together. I know I was in a small but very mighty breakout room, and we just ended on a note of like, have you heard of this foundation that could help? And like these kind of connections and networking around passion areas, around geographies, around various cross-sectoral opportunities. It's super powerful. And I feel like with these large events in Zoom land, you never quite know what the universe is going to bring to you. But I've already seen with my own eyes the randomness of serendipity of some really great information sharing and networking. So thank you all for your participation in this. Just to close out our time together, I want to end with a tremendous thanks to our wonderful presenters. I think all of them showcase really high level, sophisticated, hard work scholarship, in addition to a steadfast commitment to doing right by the society in which we live and the communities with which we work and are part of. Everybody will receive a follow-up email with the recording from today's event, as well as the PowerPoint deck. We're happy to provide that. And you should, when you exit the Zoom meeting, your internet browser should pop up with a very brief event satisfaction survey. We would appreciate your taking a minute to share with us your experiences of our time together today. We at the Rutgers Hub for Aging Collaboration, anchored in the School of Social Work, are very proud to use the muscle we've developed on doing virtual events such as these to build collaborations and connections to improve social context for aging and health equity. We invite you to check out our other events that are coming up. We have another big one coming up in the first week of April on using mobile methods as a research strategy to engage communities on work on aging. So we look for that one. I'm also going to go ahead and put in the chat our LinkedIn page. If you're not following us on LinkedIn and you're on LinkedIn, we invite you to follow us to also get information that way, as well as our mailing list. But also, it's February 28th, but tomorrow, bring it, is March 1st, and it is National Careers in Aging Month, which is an inspiration for why we timed our symposium for around now to kick off a great month to encourage all of us to celebrate careers in aging, whether aging is the lead hook for what you're doing with your career, or whether it's part of it and as part of a broader umbrella of work that you do. We acknowledge it and celebrate it, and encourage you all to go forth and expand our networks of others who might consider aging as a way to build out one's life's work. We can go to the next slide. Yeah, so just our final thank you. This concludes our time together, but we're happy to leave the Zoom room open here for anybody who would like to linger and stay on. I realize a lot of people might need to jump right at the hour. Totally respect that too. Just want to say again, thank you to all, and we hope to see your Zoom box or your live self in person soon.